Good morning, everybody. The offset, I welcome everybody for something interesting session that is on the latest advancement in cataract and refractive surgery. We have got 4 lectures in this with all leading phaco-refractive surgeon around the country. Since our first speaker is going to be Dr. Vardhaman Kankeria, he has got other talk in the other session, so he'll be talking my expectation from the ID Feki IOL. Over to you, Vardhaman. Dr. Vardhaman Kankeria is our member scientific committee, All India Ophthalmological Society also. So, Dr. Navneet Toshniwal also here. Sir, if you can come to the stage, please. Since Vardhaman is talking on the Feki IOL, I will continue with the Feki IOL next of my talk. Then he can go for cataract. We can do like that only. I told Dr. Namrata also join soon, but she's in inauguration of SSTC.
Yeah. So good morning. Thank you so much, Dr. KP, and also the biotech for the opportunity. Friends, what I'm going to talk to you about is one of my favorite refractive procedures, which is the phakic lens. And now the main thing is going to be, what are my expectations from the ideal phakic lens implant, and if there is anyone that comes close to that. Friends, we all know that the refractive surgery of today has gone through almost a century of innovations. The first refractive surgery which was ever reported was actually a posterior RK by Professor Sato, and that was done in Japan. So from almost 1920s to now 2024, we have come with a long and a very, very dynamic journey of a lot of new innovations. And these innovations have gone parallelly. There have been innovations which were happening on the corneal laser refractive surgery front, and parallelly there were innovations which were happening on the lens-based procedures, which involves your phakic lenses and also the refractive lens exchange implants. But as of today, the thing that we are come to is in the form of Contura, Smile, advanced surface ablation, and the phakic lenses are currently the top choices for our patients. But when it comes to refractive surgery generally, the first global phenomenon which actually made refractive surgery a household name and extremely popular was the LASIK surgery. LASIK was first done by my mentor, Professor Ioannis Palikaris, in 1989, and the video that you're looking at is the first ever LASIK done in the world. So this was done in Greece, and with a lot of advantages of LASIK in those times, like very, very quick recovery, a good amount of predictability for high differences in terms of myopic corrections, hyperopic correction, astigmatic corrections, no haze, and very less regression. This scored over the previous technique which was called as PRK. So in the beginning, when the LASIK was started around the world, actually there was no limit. People used to go and they used to ablate corneas for very, very high diopters. Although LASIK was approved for almost minus 12 diopters, people have gone on to treat 12, 13, 15, 18 diopters over time. And slowly when these patients came back for follow-up, it was seen that higher the intended correction, the thinner the cornea became, the flatter the cornea became post-operatively, and that led to a lot of optical phenomena because of oblate cornea. These optical phenomena was loss of quality of vision, induced spherical aberrations, induced coma that led to a lot of halos and glare in the night. Of course, chances of ectasia went up and regression was seen very, very commonly. So currently, slowly, the trend changed back to get our corneal refractive surgeries up to minus 8 or at max minus 10 diopters with the current generation procedures such as femtolasic, Smile, or Contura. And for the rest, this phakic lens implant, that is what we are going to talk to you about, have actually replaced the previous generation surgeries. So as of today, a refractive surgeon has to be well versed with not only LASIK, which is a corneal refractive surgery, but also know the nuances of phakic lenses. And the phakic lenses are nothing but artificial lens implants which are done either in the anterior or the posterior chamber of the eye in presence of the natural crystalline lens to correct refractive error. And just to give you a small glimpse of the things that we discussed, this was a nice report that we had published back in 2007 Our group had shown that in one eye, if you do LASIK in this particular patient who had minus 9.5 diopters of spherical equivalent, and in the other eye, the patient underwent a phakic lens implant, and over 10 years, it was seen the eye which had undergone LASIK had regressed to minus 1.75, and the other eye, which was the phakic lens implant, was still very, very stable with only 0.5 with a great quality of vision. So as of today, if you have minus 8 or minus 10 diopters or beyond refractive error, or in case the cornea is not up to the mark because of thin cornea, keratoconus or dry eye, and if your the internal chamber depth is 2.8 or beyond, definitely the phakic lens implants are the choice. The phakic lens implant in itself has gone through a lot of generational changes, but the one that we have zeroed down on is the location in the posterior chamber, and the first ever posterior chamber implant was done by Professor Fedorov in Russia. We know that there are a lot of phakic lens implants which are there, and the first one which actually became USFDA approved was the STAR, but now this new implant, which is the acryl lens, which has been around there for almost 8 to 10 years, has been an excellent choice and is approved also in the European region. So currently, as we have seen, the phakic lens implants have to be used in particular zone and scenario, but the beauty of phakic lens implant is that you can treat very, very wide array of refractive errors with a lot of great advantages over corneal lasers. So this phakic lens implant, which is the acryl phakic lens, we have fortunately had a very, very good experience with this. We were one of the first centers in India to start implanting them when it was introduced as a trial site back in 2014 and 15. And we have so far done a good number of these lenses. So when it comes to what do I expect from an ideal phakic lens, of course, what I want from my colleagues, for our surgeons who would like to start phakic lens implant, I definitely want that this phakic lens implant should be very easy for them to calculate. There should be very easy to use kind of scenario in terms of handling, loading and insertion of these phakic lens implants. We also want that the backup support from the company has to be excellent. The toric phakic lens implant should have a good amount of stability for rotation, and a higher refractive error customization should be possible even beyond what is naturally available with the other companies. And of course, there has to be a constant training and support which should be given to the new surgeons. We all know that when it comes to phakic lens implant, your first win is when you actually have the right power and the right size of the phakic lens implant. And when it comes to that, they have an excellent calculation tool which is available online, where you have to feed all the data that you have. And with all these things together, it will actually not only give you the lens which is going to be suggested, it will also let you know what is the residual astigmatism or residual refractive error which remains, so that you can choose the closest lens to your requirement. And it will also show you if this lens is in their inventory or not. I think this is currently the only company that gives you this online, where you can actually know beforehand if the lens is readily available or it is not. And that gives you a lot of leeway when it comes to talking to your patients, especially counseling them. There are different parameters, of course, that we have to put in. As you know, the keratometry, K1, K2, the spherical refractive error, your cylindrical correction along with the axis, your corneal thickness, pachymetry, backward distance, which is standardly taken at 12 millimeters, your white to white, which should be ideally taken by 3 different instruments, and the endothelial, or what is called as the internal anterior chamber depth. Now let us look at what is the advantage of this particular lens when it comes to handling. Now this is the other lens that we have some experience with. But if you see, these lenses, at least in the beginning, surgeons are slightly more difficult for them to maneuver or to load, because it requires a bimanual approach. It requires front loading. You cannot touch these lenses with any kind of forceps. So this is what is called as the bimanual or the front loading approach. You can see this lens is actually put in this cartridge, and you have to use a very, very specialized forceps to drag it. And sometimes if you are not very, very careful, you can tear the lens because they are very, very fragile. As against that, if you see the acryl phakic lens, if you are somebody who has been doing cataract surgery routinely, you will just see that the loading is seamless. It is extremely easy because the loading is exactly similar to your plate haptic cataract IOL. It is very, very easy. You just have to tuck it in. You can definitely, these lenses are stiffer, so you can actually handle them with forceps. you have to make sure that the flanges go under the side margins of this cartridge. It is very, very easy to load, and also this assembly is created very, very gently. If you were there for the live surgery yesterday, you must have seen in the live surgery how easy it was for me to load this lens. Now this is the implantation. You can see the lens goes extremely in controlled fashion, does not open in a erratic fashion. It has never ever opened upside down or in tilted fashion. So extremely predictable when it comes to its implant as well. So when it comes to the other support, you will be very happy to know that you get a backup lens. So if you actually are a beginning surgeon and you are going to make any mistakes in loading or in implantation, there will be another lens which will be given to you, and you can use that as the backup. That will give you a peace of mind. And one other beautiful thing that I have seen is that here you don't have to rotate the lens for more than 15 degrees, and that's the reason that actually the stability of your rotational instability of these lenses is lower and the stability is better. So if you have seen, some of the studies have actually looked at, as you go from horizontal to vertical, your sulcus to sulcus becomes wider, and that's when you go beyond 15 degrees, you will see that there is going to be a gap which is going to be created between your foot plate and the end, between your foot plate and the sulcus, and that is what causes the rotational instability for these lenses. So instead of having a 4-point contact, the lenses which require 22 degrees tilt will be more unstable. But the beauty of the Biotech acryl lens is that the tilt is only up to 15 degrees rotation, and that's the reason that this gives a very, very snuggle stability. These lenses also have other advantages because you can completely customize them. You can go even beyond -18 diopters, which is available in the other, let's say, option that is available in the industry. It gives an excellent quality of vision in the night because your effective optical zone at the level of the pupil is always beyond 6.5 millimeters, and it is hardly known to give any amount of intractable or severe halos or glare phenomenon. So what we have seen so far is that these lenses are beautiful lenses when it comes to handling them. The support that you have for the calculations is very, very transparent, and it is readily available. You have ease in handling, in loading, in insertion, and also tucking. You don't have to rotate these lenses more than 15 degrees, though the stability is much better. And most importantly, they go through a very tiny incision of 2.8 millimeters, and they are completely customizable even for any high emmetropia that you can deal with, which is the definite very big advantage. Now, one more unique thing about this lens is that when you go to hyperopic treatment, most of the other manufacturers do not have the central hole, and this central hole is required for you to avoid the peripheral iridectomy for these patients, and also to get rid of your viscoelastic which is behind the lens during the procedure. And this is something which is unique because in the acryl hyperopic lenses you still have the central hole, and that definitely gives you that big advantage. Also, they give you a good amount of complication management support because they have a lot of surgeons who are on their board, and they can help their peers to go through any complication management, a vault issue, sizing issue. You always have somebody with you. This is a very nice article which was published in JCRS, who have looked at 5 years data of this acryl phakic lens, which is now CE approved. They have shown that this is a very, very good option, a very effective and safe refractive surgical procedures over 5 years of duration of time, which is a reasonably long-term follow-up. This is another very, very unique and nice, interesting case where they have actually compared the acryl phakic lens with the VG and ICL, and what they have seen is that the outcomes when it comes to the visual outcome of uncorrected visual acuity, best corrected visual acuity, the spherical equivalent, and the residual astigmatism was exactly similar over duration of 2 years. But the most important thing is what is called as the dynamic vault. Dynamic vault means that whenever your photopic and the mesopic phenomenons are coming in, when you have a light intensity which goes up and down, the pupil, sometimes the iris tissue presses onto these lenses and can cause dynamic change in the vault, and this dynamic change was seen to be much, much lesser with the acryl phakic lens, only 65 microns as compared to the other one which was 121 microns. So definitely a great, absolutely very close to the ideal option of phakic lens is what I will say. So currently, if you have a patient who has a stable refraction, who is probably a LASIK reject of myopia beyond -8 diopters, is hyperopic more than plus 6 diopters and has still a good anterior chamber depth, has initial corneal thickness less than 480 microns, a residual bed after LASIK less than 280 micron, either a very flat or very steep cornea with significant dry eye, or patient who is already keratoconus suspect, or patients who have had keratoconus but now are stable either naturally or with post CXL. All these patients are absolutely a great options for your phakic lens implant. And these iCRYL phakic lenses have a lot of advantage, as we have discussed, and all these come into play with some certain unique features that they offer to you compared to the other manufacturers. So we have been extremely happy with these lenses so far, with almost a decade old experience, and I'm sure that we are going to hear more about this with Dr. Kudlu also. And I would like to thank Dr. Namrata and the entire AIOS team, and also LOC in Dehradun for fantastic arrangements and the kind invite. Thank you very much. Thank you.
Thank you, Dr. Vardhaman. It was really, you have covered the topic very well. It was a very nice presentation. And in continuation, we will have another talk. There are 2 talks on phakic IOL, so we can have a talk by Dr. KP Kudlu. And meanwhile, if there are any questions for Dr. Vardhaman.
Vardhaman, if to start with the phakic practice, what do you think that which are the basic machine in the practice which are needed?
Right. So the good thing about the phakic lens practice is that you really don't need extremely high-end machineries. There are 2 things which are most important when it comes to that. Number 1 is, of course, your refraction has to be very, very good. Number 2 is when it comes to the sizing, you should have if you have access to a good tomographer, which is either the Cirrus or the Pentacam, will definitely give you a good advantage, along with the current generation biometers, which are optical biometers like IL Master. They can give you a good white to white, but the most important thing that we rely on is the digital caliper. So even if you don't have access to the tomographer or the optical biometry, still you can have equally good outcomes if you have a good white to white sizing machinery in the form of a very simple 2000 rupees tool, which is the digital caliper. So with such simple tools, you can actually have a very, very good outcome, sir. Thank you.
Thank you. Thank you.
Yeah, before I start, I request Dr. Jatinder Vai also come to the stage. So just Vardhaman was continuing with the phakic lens. I thought let me continue with the phakic, and then later by Jatinder and also Navneet sir to continue with the IOL platform. So I think already Vardhaman has told about the advantage of, excuse me, not moving. Already Vardhaman has told about what are the indication and contraindication for phakic lenses. So where LASIK cannot be done, even with the patient with a very severe dry eye, even extreme steep and flat corneas, even patient with the stabilized keratoconus, you can really opt for them for phakic lenses. So these are the indication Vardhaman already told, so I don't want to highlight. But what are the contraindication? Always you should know when you are thinking about phakic lens. The history of uveitis, history of glaucoma, very important, entry chamber depth less than 2.8. Even if the patient is already started developing cataract, don't think about putting the phakic lenses. And very important, especially when you are thinking putting these lenses, pregnancy is a contraindication. Always we should tell the patient after the delivery, after cessation of lactation, after 6 months only they can plan for any of the refractive procedure. So the advantage of all these phakic lens, because it is far from the endothelium also. The one point I always tell, whenever you, whatever the vision you are going to get in phakic lens is always better than the promise, because of these lenses are always close to the nodal point of your eye. And also the one more advantage always, the other complication like with any of the refractive procedures like dry eyes, which is not going to happen with the phakic lens, and also it is a reversible procedure. So before starting, I think I want to again tell what are the A list for pre-operative checklist. Very important: subjective refraction, keratometry, antechamber depth, pachymetry, axial length, and white to white. Of course, all my patients refractive surgery, I prefer to do a cycloplegic refraction. Those who wearing soft contact lens, I tell them to discontinue for 4 to 5 days. Those who are wearing RGP, best 1 week to 2 weeks is ideal for them to come back for the refraction. Coming to the keratometry, really posterior curvature is not at all important. Normally, even those are having a good autorefractometer which has been calibrated, that keratometry reading is more than sufficient. Ideally, is optical biometric keratometry is more than sufficient for taking a K1, K2. So, posterior K will not alter overall size or shape of the phakic lenses. Coming to the antechamber depth, that has to be minimum 2.8. So, how you calculate? That is from the endothelium to the anterior capsule. So, there are a lot of equipment really measure the AC depth, but I prefer to do with off scan. But most of us are having ultrasound. Always when you are doing the ultrasound, always you should remember to detect the Pachy value. So, always deep antechamber depth or shallow antechamber depth always helps to determine the appropriate model for the particular lens. Probably I can say ACD is the only determinant which could prevent patient for getting the phakic lens. So, coming to the ACD, this is the one of the study we did with the different machine. If you see here, with the A scan and with the IOL Master 700, almost the results are quite similar. You can see compared to. So, normally I don't take from IOL Master 500 or even Pentacam is not that reliable when you are thinking about the ACD comparison. So, even ASOCT, I do have got a Visante OCT which gives a quite similar ACD when compared to the A scan. So, coming to the white to white, probably the single most important measurement which has for success for the procedure. Always you should take 2 to 3 reading. What I do in my hospital, normally I take white to white. I tell my co-consultant, after that you go and take, then we compare the readings, make sure that which is close to each other. Because what will happen if you have got a oversizing, normally you will have a higher wall leading to glaucoma, or if it is higher sizing, the chances of cataract will be very, very high. So, this is again a small comparison what we did. See, we did along with the digital calipers, and also we did in comparison with the off scan also. Results are quite similar, but when you see with the Visante, but Visante has given a very good ACD, but coming to the white to white, it's giving a over reading. So, always what we do normally under the microscope, we take them to the OT and we do. See, just again, there are 3 important points when you are doing this white to white. You are having outer limbus to outer limbus, mid limbus to mid limbus, clear cornea to clear cornea. These are the 3 points always we should remember. But always, as I said, that patient must be there in supine position under the microscope, put a drop of anesthetic. Always measure white to white horizontally. This is very important. Don't measure them vertically. Always measure them horizontally. But I do, because of my long experience, I measure from clear cornea to clear cornea using a digital caliper, my take home message. So, always pre-op observation, you should always look for any hike in the IOP. Always look for the vault also. So, what exactly is this vault? Vault is the distance between the posterior surface of the phakic lens and the anterior surface of the anterior capsule. What should be the ideal vault? Is around half a corneal thickness to the 1.5 corneal thickness. That is between 250 to 750 micron is the ideal vault for your phakic lenses. So, what are the possible complications? As I already told, you may have low vault, you can have high vault, you can have a refractive surprise, you may have an increase in the intraocular pressure, you may have a iris chafing, and even sometimes with a poor corneal healing. There's a small video actually just to share with you. Before acrylic phakic started, for 4 years we are with the company. First we implanted 500 lenses, then we came to know the results, and I don't want to again and again tell because there are some of the company secrets, but what we felt that the lens what is being provided by the other companies, all are hydrophilic lenses only. Even though it is Collamer coated, after 1 year of implantation that Collamer coating goes back, and in the end hydrophilic intraocular lens is the lens is going to stay inside your eye. So, if you have got a good ACD, I don't think so. Definitely, we have been doing this lens almost 10-12 years. Absolutely, there is no problem at all. See how I do, how everybody does the marking. Very simple. I think loading, I think already Vardhaman already told. Nowadays, acryl has come up with their This is my older video, has come with their preloaded system. So just preloaded system, just you turn, just push it inside. There is no headache, only directly from the company, the overall lens will go inside. As Vardhaman said that, very easy to implant. In my overall career, I never had any chance of flipping the lens inside the eye, absolutely no chance, and it's quite easy to implant. Probably I think those are, most of us here sitting here, all fantastic phaco surgeons. I think for you, it is, even with the one patient experience, you can make it the best of the results. But again, pre-op evaluation is the key. White to white ACD, I think you have to keep it. If your pre-op workup is very good, then I think the procedure itself is very simple. We have only out of around 500-600 patients, 1 or 2 patients might have developed cataract, and very easy to remove, and again you can do the cataract surgery quite easily. You can see here even the rotation is around 15 degrees, so you need not have to, once you inject, normally design the lenses also so well. And again I want to tell, Biotech has spent their most of the time in researching this product. The product is really, really good. So this is about the video. These are the features. I think already Vardhaman had told. All the online version and offline mobile also available, and also no chance of flip and rotation. These are the nomogram. This is how you have to order for the lens. This is our experience at 200 eyes. Patient came for follow-up for 1 week, the 1 month, 3 month, and 1 year and second year. This is the model. Different models are available depending upon the patient's values. So again, I am having some time. So mean average, see, if you see here, we have done from 18 years till 45 years, and spherical equivalent of minus 14 diopters. So corneal thickness also we measured. We looked at the axial length, ACD, and mean keratometry. So most of in our case series, 51% of the patient had that refractive error between minus 10 to minus 15. Few of them are between minus 15 to minus 20. As Vardhaman said that they can also customize and give you the lenses any power. This is how the post-operative spherical equivalent. If you see, in 46% of the patient have got a residual refraction of minus 0.5 to minus 0.01. And again, the wow effect in phakic lens is amazing. When I was going through the previous company, that ICL, almost around 14 years before, a lot of people used to shout at me, what you're doing? Nowadays, the era has come that everybody is doing phakic lens, something ultimate. So this is why, because of the wow effect. Even patient with a 660 vision with a very high myopia, if you implant, then suddenly they are going to get the vision of 618 or 612 part. Again, this is because of these lenses are close to the nodal point of your eyes. So coming to the IOP stability, if you do all your pre-op workup, IOP is not going to increase also, you will have a good results. Coming to the safety also, the patient achieving post-op uncorrected visual acuity equal to the pre-op best corrected visual acuity. Endothelial cell count was very, very less, minus 3.51 plus or minus 9.69. So 8 patients had an initial raise in the IOP which was controlled by medication. Spherical equivalent is minus or within 1.5 diopter in 100% of the patient. None of the patient in my case series except one developed cataract, and because he was a diabetic patient and then really required for explantation. These are our few experience with the acrylic phakic toric, 200 patients. The range, the patient age is between 20 to 39 years. So this is the overall model with the toric. But if you see here, refractive astigmatism, pre-op astigmatism to post-op astigmatism, in 80% of the patient had a astigmatism less than 0.25. That means the rotation is not at all there. So more than 95% of the patient had a refractive astigmatism less than 0.5 diopter. Coming to the rotational stability, 86% had less than 5 degree rotation, all had less than 10 degree rotation. In conclusion, acrylic phakic and acrylic phakic toric phakic lenses are very safe, effective for treating range of myopia and myopic astigmatism. And even we have been now started implanting patient with a minus 2, minus 3 diopter up to minus 4 diopters too. Short and easy learning curve for cataract surgeons. Quality of vision is always better than promised. Long-term follow-up studies are needed in order to evaluate the incidence of cataract and endothelial cell loss. I invite everybody to my hometown Udupi. We will be doing the Karnataka State Ophthalmic Society Conference 22, 23, 24 November. Thank you one and all.
Nice presentation. Just one question related to the surgical. How much dilatation you need before putting, if it is a very big full dilatation or semi-dilatation, what is your preferred?
So actually initially, now also I need a full dilatation. That is the first criteria for me. Because your comfortability is a must. I should not be rubbing or the iris that much. Full dilatation is very important. Last time in one of my live surgeries, what I did actually, I just, patient came with without dilatation. I used a Phenocan Plus on table. Still the results are same only. That's what I just saw Ramurthy doing. Last time in Jharkhand Ophthalmic Society while doing the live surgery, I just used this one Phenocan Plus dilated. But full dilatation is very, very important.
After the surgery, any constriction of the pupil?
Yeah, I never do, sir. If you put it in the sulcus, I never do, because putting pilocarpine again, some of the patient may develop some sort of reaction and sometimes hike in the IOP. I think better not to put, just leave it like that.
And what OVD you are using, Dr. Kuddu?
Huh?
What OVD you are using? You using simply a Hilon type of thing or just carboxymethyl cellulose?
No, normal carboxymethyl cellulose I am using. Some of the surgeons they use co-SU also, but sometimes if it goes behind the lens, going back behind the lens and again taking out, sometimes problematic, and the patient may develop increase in the IOP post-op. Best is, I think, carboxymethyl.
Carboxyl. Okay.
Thank you.
Beautifully explained, KP sir. I would now invite Dr. Navneet Toshniwal for the next talk, creating a new standard in cataract surgery with mono-mode technology, ICRIL CERT.
Good morning, everyone, respected chairperson and colleagues. We are talking on a monofocal, but advanced monofocal or more than monofocal. That's the topic. We are talking on this particular lens. Before going on a ICRIL CERT, I will just, in this figure we can see that what exactly monofocal IOL can give just for distance. And when we are using the multifocal IOLs, you can get some focal points, not the range of vision. This is very important. No need to get confused, because now monofocal we started with, then we started with the multifocal, then trifocals, and now every company is coming with this advanced monofocal or EDOF, extended depth of focus lenses. So here you can see these 3 points related to that. How to achieve this natural vision? This is very important word, and that is called as a continuous vision, not focal vision. And that means the functional intermediate. Now if you will see, most of our quality work we are doing, distance is a must for everybody, and then intermediate vision. That is, most of our job work is at an intermediate distance. That is very important. So this is already I explained that there is many terminology. It's a monofocal, advanced monofocal, or extended depth of focus IOLs, we will see. Now this is another very interesting picture, that what exactly monofocal IOL can give at a far distance 1 point. Multifocal IOL already we explained in that figure, and 3 points, maybe it is trifocal or whatever it may be. Now this is very important nowadays, is the extended depth of the focus at intermediate distance, which is very important. And now why it is important? Because any case which is indication for monofocal, you can put it this advanced monofocal. That's very important. No need to check for many other criterias what we are taking in the consideration for multifocal, trifocal lenses. This is very important. To immediately we can jump in this practice of the EDOF lenses. Now you can see here what exactly these EDOF IOLs can give is the range of vision. That is the very important in this figure. Now many companies are coming with us, they are showing their specification First thing what I do in my practice, I see the specification. How much is the 6 millimeter optic? Okay, 13 millimeter is the length. That is very, very important. That will give more stability in the bag. Then other in 0 degree angulation, then which are the formulas which we can use for to put these lenses. Most important, many lenses are we have to load the lenses. One of the best criteria of this lens is it is coming in a beautiful preloaded system. That is very important. Again, what the KPS has, hydrophilic acrylic, but this is the hydrophobic lens or hydrophobic acrylic. That is very important because this is the material of choice nowadays. Then second thing which I do, we have to use that system. I just don't go on rely on any lens. We have to see practically we should use this. This is a very good preloaded system, very simple system. Just put some water, then viscoelastics, and there are some points. These are the fixed points. You put it plunger, that's all. And just after that, with a pen grip, with one hand, with good control on the eyeball, these are the clicking sounds, and you can put this IOL. So, although it works as of what we are putting in monofocal IOLs, you can see the good rings on that. There is no other different thing, but the stability you have to check, which we are trying to see on table. After this, putting the lens, how it looks like. 5 zones are, you can see clearly here, and you have to see the stability. That is very important. This is very unique feature. Now, once I am comfortable with the design, when I am comfortable with the loading system, then I start the study of particular IOLs. Now, in this, when I started the study of these IOLs, what is the best part, which I understand, there are the 5 zones. This is very important. You can see the picture in C2 and what exactly these are the 5 zones. These are very important, very nicely explained, these zones in their brochure also. Most important is the zone 1 and 3. If you will see, is giving the higher power for distance and intermediate. Why it is important? Because when you are going to get in at a zone 1 and 3 perfectly at a distance and intermediate this thing, it is a pupil independent. That is very, very important. What is the, in any scotopic condition, photopic condition, what is the pupil and all that, whether it reflects to your result. So that is the zone and 1, 3. 2 and 5 is having the nominal power as if a distance vision. And another unique feature is in a segment 4, which contains the higher power at 60 degree interval to balance the energy in photopic and scotopic. Again, this is for the pupil dependency and independency. Another very important criteria is the angle alpha and angle kappa. Whatever angle alpha kappa, just straightforward, as if you are putting monofocal, you can put these IOLs very, very safely. You can see the depth of focus here. It's a 1.75 diopter of the focus. This is a defocus curve. And this another very important figure, when you are going to see the difference between the MTF function, the contrast sensitivity of the IOL. You can see in the monofocal, it is at a top point, but it is giving just one focal point. In these cases, in advanced monofocal lenses, it is not like monofocal, but it is near to monofocal as in a contrast, and you can get the 2 diopter depth of field. This is very important nowadays in this era of lenses. you can see this contrast sensitivity up to the 2 diopter difference between the monofocal and this EDOF lenses. It is a better contrast sensitivity up to this particular range of vision. And this intermediate vision up to the 57 centimeter. In our practice, when we start these lenses, we do some combinations and all that. Either company may or may not allow, or it is not scientifically, but minus 0.5 diopter, if you will start adding in the other eye or like that, it will give still your zone, that 57 centimeter will come to the closer. In some of the studies, I have not done big study of the many lenses, 10 to 15 lenses, but at a 40 centimeter also it is a N8. Not very clear, but small refraction may be needed for that. But up to it starts from 40 centimeter, distance was a minus 0.5 diopter, it will give the nice range of the vision. I have a machine, this is the Tracy. I will definitely recommend those who are affording this machine, Tracy technology. This is one of the unique machine which will give you the idea of the quality of the vision. For many practice, angle alpha, angle kappa, then your contrast sensitivity, you can check the IOLs. Whatever IOL you will put on this machine, you will get the idea. Here what you can see in this figure is this is the internal, this is the cornea, this is the internal. And this modular transfer function, you have to see after putting the IOL in the eye, you can check with this. If MTF is better, because if you compare the many lenses, especially in multifocal and trifocal, this will go down. But even in the advanced monofocal lenses, if you will compare the series of the lenses, you will get the different type of result. But here I got this type of results in a 6 to 7 patient. I have checked after 1 week, 2 weeks, and these are the very important results. This is the range of vision. Why intermediate vision is really needed. This is I have already mentioned. And as a clinician, now our 80 to 90% of the practice has gone for this EDOF lenses. Now many lenses are coming. Now monofocal toric, this indication has finished. Now it is the EDOF toric. Either you put EDOF, or if there is astigmatism more than one diopter, you can go for the EDOF toric. The results are extremely fantastic, and these are the two important choices of the IOL, a safe IOL practice once you do your job extremely well. We will particularly see this lens at a glance, good extended depth of focus, continuous vision, very fast neural adaptation. This is a very big difference than the multifocals and trifocal. Of course, glare halos can come, but there is a very minimal glare and halos. I have already mentioned about the pupil dependency set. Performance in all light condition is extremely better, and we have seen the aberrations also. That is the reason. So, in practice, whenever you can go with particular lens, first see the criteria. Second is the ease of the procedure, and then you start the study by yourself. You should not depend on the particular surgeon or this thing. They are giving the references, but you start using this thing, and once it is a customized everything, then you will start getting the advantage of these lenses. So EDOF, advanced monofocal, is the choice with all these very impressive points of this lens. This is one of the good choice in my practice nowadays. Thank you very much for your patience.
Thank you, Dr. Navneet sir. You have been a genius from, I think, during our early days of practice. You are the one few person in India who was doing the cataract training, I think, way back in year 1995, 96 also. So as you said that, I think the trend should go towards for every patient, we should give the best of the best quality vision. I think monofocal is going to be come down, and most of us that choice of lens is going to be the advanced monofocal or EDOF lenses, the lens which has got no rings on that with a less glare and halos. I think there is going to be the coming days. Thank you. I think sir has already told about the advanced monofocal, but still some of the patient really expect they need to have 6 and N5U, and they don't have any active night life, but they need to have very precise vision when they close each eye and see.
Exactly.
So my friend, none other than Dr. Jatinder Bhai from Lucknow, he'll be talking about the achieving spectacles independence with trifocal bliss technology. My experience with Optiflex Tray. Over to you, Jatinder.
Thank you, Dr. Kudlu, and respected seniors on the dais as well as the respected delegates. A very warm welcome. See, this word achieving spectacle independence is just like when you are talking about your young teens, when you are 22, 21 years, and you really don't need anything. You really don't bother for distance, intermediate or near. It is just without glasses. Except you have got a cylindrical problem, then you need glasses. But otherwise you jump off and on. But as you grow old, when the matter is when you come to 70s, 60s, now ye dil maange more, you need something more. We have been correcting your distance vision, you were so happy with that, but now it was कि हमको तो पास का नज़र नहीं आ रहा है, this is a big problem. So then you jumped for the bifocals, and then as Dr. Toshiwal said, it was EDOF, and then came the trifocals, although they were there. So I'm going to take just 5 minutes. I'll be not talking much of the science, but I will be talking about what exactly this technology is and how you can harbor in your practice. Having said so, the landscape of trifocals, or as say EDOF in India as such, is that many national as well as international companies are into this business, and they are making really good lenses. And when you speak of trifocal, they want to tell you that you can see good at distance, you can see really good at intermediate zone, as well as you can see well for the near. But then the point of education to the patient is that we are talking this when you are talking for operating both the eyes. जब दोनों आँखें operate हो जाएंगी, then we can talk about these good distance, good near and good intermediate. It's not only one. And the second education point is, ask your patient not to do this. अभी इससे check किया, इससे अच्छा दिख रहा है, इससे अच्छा दिख रहा है. No, this comparison should be abolished, because that neural adaptation point and this, the education of getting both eyes operated in a shorter period of time is must. So having said so, see, when we talk about trifocals, the majority of the national and international companies are, as I have said here, they are going for refractive diffractive technology. So there is no need to shout for this problem also, कि अगर आप trifocal कराएंगे तो you will be having glares, halos. This is bound to occur. This is, you cannot defy the science. The moment you give a diffractive scratch on a lens, the moment you scratch a lens, the diffraction will occur. As you can see, it is, what is this? This is a pure, it's a pure bispherical lens. उसके anterior surface पे आपने rings खींच दिए हैं. So you have made those rings. The moment light goes through these rings, the diffraction is bound to occur. The moment diffraction is bound to occur, halos, noise, glare होना ही होना. You cannot avoid it. It is a science. But the question is, कितना कम कर सकते हैं? How minimum we can achieve this glare and halos? This is the science, and that is why we are stepping forward, and we are also aiming at कि हम rings ना बनाएं. हम, as Dr. Toshiwal said, हम EDOF lenses use करें so that we really don't need. लेकिन तब भी you cannot defy science. The diffractive technology counter over a refractive technology. These lenses are diffractive, refractive lenses. Glare, halos, noise होगा ही होगा. Even if it doesn't happen, the total internal reflection will happen, and the peripheral edge can also cause the problem. So just forget about it. Don't overemphasize. The majority of the surgeons who are operating, they do not have themselves a trifocal inside their eye. They do not have EDOF inside their eye. So they cannot talk with that confidence. हम तो वही बोलते हैं ना जो हमें कंपनियां बता रही हैं, जो हमें कंपनियां सिखा रही हैं. But the matter is different. जब अपने पे बीतती है तब पता चलता है कि exactly science क्या है. Having said so, the basic thing is, you have to understand that you have made rings. See, you have made rings on the lens. ये आपने rings बना दी हैं. The nearer the rings are to each other, more is the add power. The far off the rings are away from these are, less is the add power. This is one point. The second point is how deep these rings are. What is the height of these rings? If the rings are really high, the scratch is really deep, the height of the ring is more, the energy of light will be distributed to those focal points in that quantum only. पर एक बात याद रखिए, अगर total light is 10 candles for example, तो ये 10 कैंडल ही बटेंगी. Either you distribute it for distance, you bring it to near, you bring it to intermediate. ये 10 का ही खेल है. You cannot make it 12, you cannot make it 9. Now, if there are 10 candles, you can send 6 candles to distance. You have got 4 candles now, you distribute 2 to the intermediate and 2 to the near. तो ये भी चिल्लाना, ये भी noise मचाना, हल्ला करना कि you don't have this, what do you say, quality of vision अच्छी नहीं आ रही है. Quality of vision will only depend what is the distribution of these candle of lights to all these points. So everything is compromised. Everything is compromised. But the question is how well you go ahead with this. Having said so, the optical principle of bifocals and trifocals, as I have told, the spacing will control the power. अगर आपकी ये रिंग्स बहुत पास हैं तो the ad becomes 3.5, 4 जैसे पहले रिस्टोर में आता था एल्कॉन का. You space them more, the things will become, light will be shifting to the intermediate zone. अगर आप इस रिंग्स की स्पेस को बढ़ा दीजिए, the things will become intermediate. And similarly, when you see the height, अगर रिंग्स की हाइट ज़्यादा है, they will diverge the light to the point. For example, if आपने पुराने ज़माने के कूलर देखे होंगे, कूलर के आगे एक ग्रिल लगी रहती है. Now, if the fins of these grills are too big, and you turn the grill, the air will come to one point. If you make those grills very short, अगर आप height कम कर दें, तो आप जितना मर्जी ऊपर नीचे करते रहे, the air will flow anywhere. It won't be precisely going to at one point. So heights have got a very important. इसी से apodized and non-apodized का concept आता है. So when the height is absolutely same, okay, no problem, no matter the pupil becomes smaller or larger, the light will pass off. चलो. Having said this thing, I will not take much on this thing. The question is how to switch from a bifocal to trifocal. तो trifocal में हम कुछ एक्स्ट्रा नहीं करते हैं. हमने जो bifocal टेक्नोलॉजी है, एक डिस्टेंस के लिए एक हमने क्वांटम बनाया, एक नियर के लिए बनाया, फिर हमने एक सेकंड सेट ऑफ रिंग्स क्रिएट की, दैट इज फॉर डिस्टेंस एंड इंटरमीडिएट, और हम दोनों को सुपर इम्पोज कर देते हैं. एंड दैट लीड्स इनटू दिस क्युमुलेटिव टेक्नोलॉजी विच इज नोन एज trifocal technology. So we have got 2 rings superimposed over this, and we get a trifocal diffractive non-apodized because the height of the rings we have kept same. Having said so, we distribute these 10 candles for distance, intermediate and near, and it is our selfish purpose how we achieve it. After talking about this thing, it totally depends that how you start your journey for trifocals. See, the operation is very simple. वही cataract surgery है, वही equipment है, सब कुछ है, but the basic thing is कि you are charging a premium amount for a premium patient who has got a preset of mind कि मैं कोई बहुत बड़ी सर्जरी कराने जा रहा हूँ. I am going for the premium most surgery. उसके expectation levels are very high. Having said so, your error का margin बहुत कम है. You don't have much margin for error. So be very particular, right starting from slit lamp, right starting from optical biometry. Please do scan the retina, or they physically see it or do an OCT, and if possible please do the topography so that the margin of error should be less from your side. बाद में कुछ होता है तो देखा जाएगा, but इन 4 चीज़ों में बेसिक गलती नहीं होनी चाहिए, as well as evaluation of dry film. दूसरी बात, एक बात और is very very important. Those people in India who are having a florid state of diabetes, please be careful because with age आप सर्जरी करके हट जाओगे, but his diabetes will go on progressing from 1 to 2 to 3 stage. He is not going to care for it, but as the retina gets bad, he will always put the allegation on the lens you have implanted. So please choose the patient also very rightly कि आप किसके अंदर क्या lens लगाने चाह रहे हो. Therefore, choosing the right person, that whom you are really going to give a technology, because if you are wrong at this stage, it is the technology which will come at blame. So be very seriously see that patient is really interested in spectacle independence. He is an easygoing personality. Type A ना हो. He is willing to understand the limitations. जब आप उसको कुछ बातें कर रहे हैं, how much time he is interrupting you, and with how many people he have come to your chamber, as well as he is an indoor worker or a retired worker. Keeping this in mind, be very careful while choosing a right person for this technology. And the IOL formula which you should use is, what I recommend is Barrett Universal 2, and I think most of the people here, they just follow this, that Barrett Universal 2 formula is a right formula to be, because it takes care of all the validations. Now, this is all available, and now majority of the people are having this in their equipments. As I was listening to one of the talks of Dr. Kuddu, he has given just an exclusive talk on angle alpha and angle kappa when he came to Lucknow. This is a big point in the mind of surgeon कि अगर angle kappa बड़ा होगा या angle alpha बड़ा होगा तो हमारे patients का क्या होगा. This is another very serious talk. Now, having said so, this has to be measured, and it is available in majority of the good equipments. For example, IOL Master or Pentacam or iTracy, you have this figure. So the problem is, it is not this, but when you are going for a surgery, how do you effectively place your lens? That effective lens placement is very important. I am going to talk about Optiflex Trio. Then what we keep in mind is, if the central zone is really big, then it defies, because it gives you a much comfortable zone to avoid angle alpha or kappa. But if you get an angle alpha or kappa which is more than 0.5, then you must realize that majority of the light in the normal stage of life is going to pass through diffractive rings, and then it is going to cause a problem. इसलिए ये point भी जानना बहुत ज़रूरी है, and it has to be kept in mind. So, for all practical purposes, if angle alpha is more than 0.5, try to restrain from going for these surgeries. And then, before I talk about Optiflex Trio, counseling, please yourself get involved in counseling. The words said by your counselor, the words said by you are two different things. Ultimately, पैसे आपने लेने हैं, नाम आपका इन्वॉल्व होना है, सर्जरी आपने करनी है, तो जवाब भी आपको देना पड़ेगा. उस समय वहाँ क्या बातें हुई थी, वो बातें नोट करते रहते हैं, and they have got so many expectations which you are going to counter protect, then it becomes very difficult. So please give another 5 minutes. आप normal surgery से ज़्यादा पैसे लेने जा रहे हो, so please give some extra time to counsel. Make them reassure, make them give a realistic expectations, because you are becoming spectacle independent, but you are not getting free from spectacles at all. वो जादू नहीं होने वाला है, and it will never happen. And moreover, there are tips and tops in the journey. A very well done surgery also can have a little tilt in the IOL, and that can give to comas, flashes of light, tailing of light, and you are into a bad situation. So just counsel properly and with reasonable expectations. Normal trifocus के साथ advantage ये है that you have got a very good vision for distance. You can see your car dashboard very well. You can shave well before the mirror. Even you can see the watch before you nicely, as well as sign your checks nicely. So advantage तो है. Those people who are not very mobile, they want to read their books. Advantage तो है. But there is a pinch of salt with this technology also. So counseling is very important, and do yourself get involved in counseling. जितने भी ये hypercritical patients हैं, perfectionist हैं, night drivers हैं, night drivers में भी वो जो high heighted vehicles चला रहे हैं, for example containers, those who are driving the containers, उनके और पोल लाइट्स के बीच में डिस्टेंस बहुत कम रह जाता है, then it's a big problem that you have a absolute glare, absolute this thing. Moreover, जब highways पे अब आप जा रहे हैं, तो now all the highways in India are also getting a big dividers now, and they have got a plantations, and so things are getting better. Technology is improving, lenses are improving, things are getting better. But high-heighted vehicles जो drive कर रहे हैं, please do not give them these lenses. So I'll just take one more 2 minutes more. Now I'm going to talk about Optiflex Trio. The lens which I'm going to talk is, now this lens has got a beautiful distribution of light for, as I told you, for distance, a reasonable light for intermediate, and a very good light for near vision. So you don't have any glare or minimal glare, but with this beautiful distribution of light, you have got a perfect vision. This lens is exactly giving a 3.5 diopter of near addition and 1.85 intermediate. तो एक reasonable length, arm length आपको मिलती है जो आपको panoptics में भी मिलती है. So you can see a good intermediate as well as a reasonable near. But when you operate both eyes, the things become magical. You really start enjoying. And more, just 1 minute. And moreover, this lens is a lens which is a hydrophobic lens. It is with a diffractive refractive technology, and this lens has got a bliss technology. I just wanted to talk about this technology. This lens has distributed the rings in form of central refractive core, 4 mm diffractive core, and rest for the again refractive core. Rings के बीच का distance जो है वो भी light को distance में भेजता है. So virtually you do not waste light here. आप 88% लाइट यूटिलाइज कर रहे हैं, और जो लाइट भी इन रिंग्स के बीच से निकलती है, इट इज गेटिंग बैक टू द being used for the distance vision. So for all light conditions, you have got excellent distance, good intermediate, and reasonably good near when both eyes are operated. Thank you so much.
Thank you, Dr. Vai, for a very nice coverage of the whole topic. Actually, what you told in the end, that it depends on the, I mean, you have to select the patient. Patient selection is very important. Maybe you can come here. Patient selection is very important, because there will be some patients who may not be fit for trifocal. Then in those patients, advanced monofocal lenses are the ones which can be used. And life is all about compromise. You have to do some degree of compromise about it. Like if you are using advanced monofocal, for extreme near work you have to use glasses. If you are using a trifocal lens, there may be a little bit of photic phenomenon, but if you are adjusted to that, then it's okay. Like the progressive glasses, many people, they are not comfortable with progressive glasses, and they cannot adjust to it. But there are people who can do it. Like I am myself using progressive glasses, and the day I started wearing it, that day only I went and did a transplant procedure. So it's just a question of how well you tune your mind. And it all.
And I would also like to say to all young and old people, learn to say no also. अब majority of time आपके पास इंश्योरेंस वाले आते हैं, करा लीजिए, उसे नहीं अच्छा देखेंगे, करेंगे. After 4-5 times सोचते हैं अच्छा बहुत बार आ गया, चलो अब करा लेते हैं. Try to say no. It is really not required to say yes to everybody. Those patients who don't fit into this category must be said no, कि तुम्हें trifocal नहीं लग सकता. He can go for EDOF lens. So counseling and choosing a patient is a big boon, because that is going to stay for a long practice. Thank you.
Any question?
Rajesh, this question for you, that suppose we don't know exactly which patient is satisfied with these progressive glasses or not.
Yeah.
So how to select this group of patients? What do you mean by selection?
Yeah.
So patient will say distance तो ठीक है, नज़दीक का भी थोड़ा बहुत दिखना चाहिए, और ये भी दिखना चाहिए, like that. So what are any specific things you are doing in your practice for this selection criteria for which IOL and all?
Yeah, absolutely. That is very right. And these things can be slightly different with different individuals.
Yeah, please.
But what is most important is that you have to spend time with the patient and see to it that whether the patient is very finicky about photic phenomenon, whether he is into very much late night driving, etc., whether he can adjust, whether by talking to the patient you will get to know that whether he is willing to make little bit of compromise or not.
Many patients don't know anything.
And no, that is true. And if whether the patient wants complete spectacle independence. If he wants complete spectacle independence, after explaining to the patient that there can be some nighttime glare, etc., you can go ahead and do it. What is another important thing is that for patient selection, if it is possible to get the angle alpha done, then it is very important, because we have explanted, I have myself explanted one IOL because of very high angle alpha. It was not evaluated, actually, to tell you frankly, but it was not evaluated before the surgery, and the patient had a lot of problems. So with high angle alpha, things are bad, but these days we have these days we have lenses which have the central rings have a larger diameter. Earlier the central rings were smaller, so even an angle alpha of more than 0.4 was creating problems. But now we have a central ring of about 1.2, 1.4, so angle alpha of 0.6 also is acceptable.
Just adding on to Dr. Rajesh, I've been doing this presbyopic practice both in the laser platform and in the lens platform probably last 14 years. I started and still continue to do with presbyon, which is the laser blended vision from the eyes, and also I do with any of the lens platform. So my chair time for any patients undergoing this presbyopic correction is 45 minutes minimum. I spend 45 minutes with the patient. Because of first point, I keep looking, I myself look at the first point, I look at after the intersegment examination with the torch light, I look at the pupil size also. Patient with a, suppose if it is a mesopic pupil's size is very small, and these patients will never grumble at you. Even if you put them trifocal, they will be very, very happy. Where the problem arises, first of all, if their mesopic pupil size is bigger, if it's like around 4 mm or 5 mm, this patient really you cannot afford to put a ring lenses. Then this patient definitely going to cost. Of course, as you said in your presentation, to have eye trace is definitely it's a good investment. Those who really want to go for a premium practice, as Rajesh said, that you need to really know about the angle alpha and angle kappa. Of course, for me, laser refractive surgery, I look at one more point in eye trace about the dysfunctional lens index also. DLI is also so important that sometimes DLI also make a really change, that sometimes you may have to really think about, other than going for laser, directly go for lens options. Again, now the lenses are coming, of course. Just talking about a couple of points about this Optiplex Trio, probably Optiplex Trio and advanced monofocal. Since I am a board member of Biotech also, we have been doing trials from last 10-12 years. Before they launch, they normally 1 year before they get the lens to us. But the excellent lenses, the glare and halos with this lens are much lesser. Again, pre of that pupil condition is very, very important. If you see the pupil is small, just implant trifocal, happy. Or again, what Rajesh said, that you have to spend time with the patient. There are some patients will be like, when you are talking to them, after 10 minutes you feel that they are very hypercritical patient. So a little bit, I can't do this. Then try to avoid them, because whatever best you do also, they'll grumble. So this kind of patients you have to be very careful. But some patient, no active nightlife, I don't drive. Even though sometimes pupil is bit of this thing, they are going to compromise that. Thank you.
And Vahi has also mentioned the personal counseling. That is
Yeah,
the very
yeah,
great
yeah,
point, in
yeah.
at least in a small private practice at least.
Absolutely. And again, we also have to check the retinal status. Anything in the media, starting from the tear film to retina, if there is any issue, we should avoid trifocals. So that is again an important issue. But as you said that yes, chair time with the patient and spending time with the patient is important.